bring exam and admission form, stethoscope, as well as pen torch. Pen torch is important because we need to make sure it's only important when we want to check pupil, okay, and usually for neuro examination. And we really need to make sure that the battery is functioning. Make sure that you bring a spare battery, maybe 1 or 2 batteries, just in case the pen torch somehow non-functional on the day of exam. And the fourth thing perhaps you need to bring is a small watch. And the watch should not be wear on our wrist, okay, and it should be just hang, either you can hang it at your shirt or you can hang it at near your belt level, okay. So, and the small watch is something that we need to bring just to time our heart rate, basically just to time our heart rate, because respiratory examination we are not expected to tell the patient respiratory rate. We are just going to tell whether the patient is in respiratory distress or not, okay. So it's mainly for the heart rate timing in cardiovascular station. The fifth one perhaps is optional. I bring it during my exam and I managed to use it, but it's optional whether you want to bring it. Perhaps just one small coin put in your pocket so that you can assess the hand function. But you can also, if you don't want to bring, it's okay, because you can also assess other hand function like hand grip, assess key turning, or even pencil grip. Just pass the patient a pen to hold it. That's also acceptable, especially if there's any rheumatoid station. So not necessarily want to keep a coin with you. So now it goes back to the important point of the marking sheet. You can see that this is the 4 short cases station that we really need to score, and you should aim for perfection, meaning to say you should aim a full marks for all these 4 stations, because if you do that, then your 5 components is almost secure. Okay, if you got 16 out of 16 in physical examination, you're pass. Okay, if you got 16 out of 16 in the sign, you also pass. Clinical judgment 16 also pass. Concern, there's no concern, sorry. Judgment is something that in communication as well as clinical consultation, you should get more. But under the discussion, you should aim perfection as well. If you aim that, definitely this component is also passed. And welfare engineering, if you don't suddenly, for example, palpate a patient that is in pain before asking whether the patient have any pain, or doing anything that is a bit dangerous, usually you will get full marks. So you can see that this is the 4 station that we should aim for at least perfection, because you only left with communication skill component and the concern that you need to tackle in the subsequent consultation as well as communication skill. Okay, so this is some general advice in terms of the short cases. We should keep calm, as well, especially the first 5 minutes of preparing the station. So in the new format, station 1 and station 4 is going to be short Tom skill followed by short case. So for that, the first 5 minutes of this both station, at the outside of the scenario, you will be focusing more on preparing the scenario of the communication, and generally you don't need much time to actually prepare for the respiratory or abdominal examination. Basically, after you complete the com skill, you should go and exam. Okay, so I foresee that for respiratory station, which is station 1, is going to be a bit stressful, because respiratory station is always the station that we tend to, lack of time and unable to complete the full examination. But if you practice thoroughly, you should able to do that well. And abdominal station is generally quite, I would say, expected. And then generally, most of the people would not find any difficulty in abdominal station. The station 3 is the one that cardio neuro is the one that tend to be 50-50 sometimes, because like I say, cardiovascular station is a station that we need to score, and sometimes if you kind of miss something, miss a sign, for example, let's say you present a dual valve replacement as a single valve, be it mitral or aortic, your marks is only half of it. So it is very straightforward, at the same time can consider a killer for cardiovascular station, while for neuro can be also a bit unexpected sometimes. But generally, I will talk you all through what are the general approach and what are the cases you are expected. If you prepare using this kind of approach and what kind of possible cases that can come out in exam, usually you should able to score them quite well. The problem with neuro is always the time allocation, because you need to be focused, make sure that you don't examine unnecessary thing that examiner didn't calibrate as a sign, or even physical examination skill. Okay, so generally you can foresee that the station 1 perhaps will be more stressful compared to the previous format. Always the BCC station 5 is the most stressful. But now that I can feel that station 1 will be actually more stressful, because respiratory system is something that you really need to give yourself a bit of calmness before you start to examine. Okay, so second point is actually, once you go inside the station for short case, you should greet both examiner and patient. Although you are very nervous inside, but you remember to maintain the professionalism, express your friendliness. Just if you wear mask, some center they don't advocate to wear mask. Like my last attempt also, there is something like optional. Examiner tell you you can wear, you don't need to wear, it's okay. But generally we all still wear because we don't want the examiner to look at our nervous face, avoiding all the facial expression, right? So generally we will, I mean, depends on whether you want to wear or not, but generally you need to express some friendliness lah, don't try to feel, try to show your nervousness in front of them. Just chill, and then just examine like what you used to practice, and then just tell the examiner, just greet them, good morning, good morning sir, okay, and good morning to you, so I'm going to examine you today. So you have to look through the stem as well. Make sure the stem you really read through at least 5 seconds. Don't read too fast, because sometimes what happened was, sometimes for example cardio and neuro, sometimes you may get neuro and then cardio. It's not always neuro followed by cardio. Sometimes you can get cardio and then neuro. So sometimes it depends on how they how they put the patient and the floor location of the exam center. So you need to look at the exam stand properly. At the same time, you must know what is the chief complaint. Can the chief complaint is a lower limb weakness, for example, leg weakness? Then you know that it gives you some clue. For example, the cardiovascular station, they tell you that patient is having shortness of breath. Please perform cardiovascular system. So if you know that that is the stem is actually shortness of breath, shortness of breath may be the chief complaint and means that patient is symptomatic. Let's say you found a mitral regurgitation with atrial fibrillation. So if the examiner asks you what is the severity, then your severity is automatically severe mitral regurgitation, okay, because patient is symptomatic. So the clue sometimes can help you, especially the stem. Next thing is, after you talk to the patient, before you talk to the patient and introduce yourself, you should wash your hand. This is something that you always need to remind yourself. Wash your hand, introduce yourself, and then after that, you position the patient and position yourself also. Make sure that most of the time we need to stand at the end of the bed. Any station also, it generally applies. We have to stand end of the bed just to observe the general condition, just for showmanship as well. And sometimes you may need to expose necessary part, okay? And be aware of your surrounding. Make sure that is there any devices or any walking aid or any walking assistant that may be important. If there's no, sometimes you have to take out the drawer and see whether there's anything hidden there. Okay, so please take your time. Usually you can spend about 10 to 20 seconds just to look at the patient. Okay, and before you touch the patient, you should ask for pain and please be gentle. And we should really practice enough to finish all these 4 stations within 5 or 6 minutes. Okay, every scenario is possible, every station is possible, but we need practice. And this is something that I feel is quite useful to show our welfare, which I tend to do for all my patients, especially in the real exam as well. Usually, after I finish examining the patient, especially cardiovascular, we tend to finish faster. And what I usually do is I will cover up the patient back. We don't have to button back the patient's shirts, things like that. We just need to cover up, make sure the patient is not exposed, and we should say thanks to the patient. This very small gesture can actually give a good impression to the examiner, to show that we actually very professional. We are not in rush. We are not very kanchong, very nervous. So just close back the patient, and then after you say thank you to the patient, you face the examiner, and you don't ever look back at the patient later on, because you're going to start to present. Okay, while you are starting to present, or perhaps before you present, you should straight away start. I'm going to end my examination by checking this and that. Only then you proceed with examination. But generally, when you start present, don't look at patient. Some examiner, they are very particular on this. If you look at the patient, they will reduce some marks over the welfare part, or here and there. Okay, it's their general impression. And make sure that you maintain a good eye contact, especially you have present the case to both examiner. Usually there will be 2 examiner. Make sure that the both examiners, you actually allocate your eye contact adequately for both examiner. Don't just look at one examiner. Generally, only one examiner will test you, will ask you question, and also will give you hints. The other examiner will usually keep silent. But remember that both examiner actually give you marks, so you need to spend your eye contact as well for both examiner. Okay, and like what I mentioned, remember to offer and complete examination. Okay, so we'll start with abdomen first. I hope that I can finish this session by just about 2 hours. So abdomen station is generally, we know that it can be gastrohepatobiliary, can be renal abdomen or hematoabdomen. If you want to simplify it, perhaps the most important thing is a renal or non-renal abdomen. Okay, because hemato and gastrohepatobiliary is something almost the same approach, but renal abdomen is something that there's some additional thing you need to check other than performing your usual routine. So this is what I did when I was preparing for my exam. This is a bit lengthy. I'm not going to go through all, but generally I will classify the hepatobiliary station to be either you're dealing with a chronic liver disease, either you're dealing with enlarged spleen, liver, or both, either you're dealing with ascites per se without any obvious stigmata of chronic liver disease, either you are dealing with very normal abdomen, but there is a scar, some devices like stoma bag, PEG tube, or either you're dealing with also just a scar without any obvious clue, like transplant. So these are some things that I tend to remember when I started my preparation. What are the stigmata of chronic liver disease? What are the signs of decompensation? What are the signs of to suggest hepatocellular carcinoma or IBD or hemochromatosis or primary biliary cholangitis? And for renal abdomen, generally, you need to classify your presentation into a few domain, I would say. Later, I will talk about it. Don't worry about all these things. Hemato, generally, I like to classify them as whether the spleen is enlarged and whether you feel any lymph nodes and whether patient have any tinge of jaundice to suggest hemolysis, or usually the fever, unless the station, the scenario offer you in the stem, usually the fever is something that we won't be mentioning as well. But this is generally a very useful guide. Let's say patient have splenomegaly with palpable lymph adenopathy. Let's say that is very obvious cervical lymph node, okay, and you are dealing more with lymphoproliferative disease. If you cannot find any lymph node, it can be myeloproliferative or lymphoproliferative because we don't really have time to examine all the lymph nodes, okay? And if there is enlarged spleen and there's jaundice, so you're dealing more to hemolytic disease. And if the patient is having splenomegaly with fever, then you are thinking either it's inflammatory causes or infective causes, okay? So I won't go through all that. I will just going to go very brief. So we have to complete examination by doing these few things, okay? So to make it short, this is how I summarize it. Hepatobiliary, you're focusing on all these possible scenario, and bear in mind that sometimes the scenario may not just be these three. It can be like just a ascites or just liver transplant scar, or IBD as well, or even just a suprapubic mass. No? So renal abdomen usually quite expected is either adult polycystic kidney disease or some evidence of renal replacement therapy, be it transplant or can be combination of these both. Okay. Or sometimes maybe you feel that is only that is bilateral kidney, but the cause of the bilateral kidney is actually due to diabetic nephropathy. It's possible as well because of evidence of the lipodystrophy over the paga umbilical area, and generally the kidney is not very huge. For hematological condition, usually the commonest is the thalassemia. They tend not to bring myelo or lymphoproliferative kind of patient, but there is also another possibility. Let's say those patients stable one, for example, myelofibrosis patient, very huge spleen with also hepatomegaly, they may bring them for exam. Okay, so in terms of preparing the presentation and your etiology, you need to prepare your own sets of template. This is my own template. There's no right or wrong way. Everyone got own types of template, but this is generally how I prepare. I will classify into a few domains, 6 domains in particular. I'll talk about toxic, infective, inflammatory, infiltrative, vascular, and others. Okay. So for example, causes of hepatomegaly, you need to really have this framework in your mind when you go for exam. This is something that you can prepare before you go into exam. Like now, if you go through this approach again and again, rehearse it again and again, then it's very easy for you when you offer your etiology. So let's say there's just huge hepatomegaly, and there is also stigmata of chronic liver disease. So you want to offer the commonest being alcoholic liver disease. In the elderly, you want to put the hepatocellular carcinoma or even mitotic lesion of the secondary metastasis. Okay, you want to put it first, and then infective is something you need to mention, hepatitis or liver abscess. Inflammatory can be AIH, PBC, PSC. Infiltrative or metabolic is like it's either fat, iron, or copper. Okay, usually we talk about these three. You want to talk other thing which is a bit rare, like glycogen storage disease. That's why I put it here because I don't want to mention it under infiltrative because it's very rare. And you also need to mention about vascular, which can be due to congestive hepatopathy, secondary to right heart failure or tricuspid regurg, can due to constrictive pericarditis or thrombosis like Bukhari or portal vein. And the other thing, if the examiner asks, until the end you cannot find, perhaps you can mention cryptogenic. Okay, but something that you want to mention before cryptogenic, you may want to mention about other common things. Okay, less common thing. So this is how I generally frame myself, and this applies for hepatosplenomegaly and also splenomegaly as well. Just a bit of twist and here and there. So you need to prioritize. Let's say patient have, when you examine the patient have a tattoo mark at the back. Okay, and patient also got stigmata or chronic liver disease. So you may want to put your infective causes to be number one instead of still following this priority. There's no specific priority in this chart. It's basically just a chart for you to remember. Let's say patient is very obese. It's like really, really obese, scaphoid abdomen, and you found that it's a hepatomegaly. So you may want to mention about muffle D as your first differential, followed by this other thing. Okay, you have to prioritize yourself. So splenomegaly, go back to the same approach, can be mitotic, infective, inflammatory, infiltrative, vascular, or others. Okay, for example, mitotic, it can be what? Splenomegaly mitotic is mainly either lymphoproliferative or myeloproliferative disease. It can also be due to chronic hemolytic anemia. Okay, like thalassemia. If you go for UK or Middle East, I mean those, for example, hereditary spherocytosis are more common, and it can also come out as a chronic autoimmune hemolytic anemia. It's also another possibility. And second thing is infective. Infective causes is important for us to mention a few things. For example, you want to mention, you can classify into different etiology: bacterial, viral, or parasitic. Bacteria can include malaria, infective endocarditis, brucellosis, IE, for example. And viral causes usually the CMV, EBV, and also the hepatitis. Parasitic, not common, but if examiner tell you that the patient returned from Africa, returned from Egypt, then you may want to mention this uh, leishmaniasis or schistosomiasis. Inflammatory, basically, we need to always remember Felty syndrome as possibility of splenomegaly, isolated splenomegaly, can be due to Felty or SLE. Okay, and infiltrative usually is all the deposition disease. Here you can see there's a bit of changes because splenomegaly usually don't cause. I mean, isolated splenomegaly is less chance to be muffled D. Muffled D, the liver will be enlarged as well. So usually for this one, you may want to consider like amyloidosis, hemochromatocytosis, hemochromatosis, and Wilson disease. And usually the commonest cause of splenomegaly in the exam is still the vascular, which is a cirrhosis with portal hypertension or splenic vein thrombosis, for example. Okay, other rarer causes like sarcoidosis or percussion solis is possible, but I tend not to mention it. So it depends on how you prioritize. Just go by your approach. What are your signs that suggest to which one? If you cannot think of anything, I mean, elder group, you want to think of mitotic. Younger group, may want to think about infective causes. And if got stigmata or chronic liver disease, you may want to present the vascular causes first. Okay, so this is generally the approach. How about hepatosplenomegaly? You're combining both together. So under mitotic, it's no longer uh, just like splenomegaly, no longer myelo or lympho or chronic hemolytic anemia. You also need to consider the causes of hepatomegaly that eventually lead to portal hypertension and splenomegaly, which is usually the alcoholic liver or the hepatocellular carcinoma with portal hypertension. Okay, infective causes, same like splenomegaly. Inflammatory is more like liver cirrhosis, sometimes can have enlarged liver as well. And infiltrative, just combine all of them. Hepatomegaly and vascular is still something that is possible. For example, there is a hepatic congestion, or there's a hepatic vein thrombosis or portal hypertension. Hepatic portal hypertension or Bukhari syndrome that can actually leads to portal hypertension. Then it's also another possibility. And other thing is like what we mentioned. Bear in mind that acromegaly, when you come to exam, especially for clinical consultation, you also need to feel for abdomen to feel whether there's any enlarged liver or spleen. But in a short case, we are not expected to mention that unless you really find clinically the feature got some acromegaly kind of feature. Okay, yes, I mean the hand is so huge, and then you look at him, there is a acromegalic facies, no, prominent supraorbital ridges, and also the macroglossia, all the enlarged interdental separation, things like that. Okay, so for abdomen, generally you want to mention after you immediately finish your examination. Generally, I usually finish examination by about 4 minutes and 30 seconds to 5 minutes. Actually, I got about 1 minute left. So how I do is I examine from peripheral. Before examining from peripheral, I stand at the end of the bed, look at the patient, find some devices, looking at the patient in general, and you may want to expose the patient. At this point of time, you may not choose to, but make sure that the screening for abdomen will be, make sure the patient expose the hand up to the at least up to the arm and the forearm. You can see well whether there's any fistula so that you don't miss them. Okay, but abdomen not necessary to expose at that point of time. Then I will go near the patient at the right hand side, and I will start to examine the hand and go periphery, everything, check the eye, check the mouth. And at this point of time, some people may check the lymph node first, but to me, I mean everyone got own approach. There's no right or wrong. To me, I will focus more on after I check the oral cavity, I will check at the chest, check at the axillary hair, asking patient to actually put their hands over their waist, and then so that I can open up the axilla and look at any axillary hair loss. And then I may want to check for gynecomastia if a male patient. Then after that, I will straight away proceed with abdomen. And make sure that if the patient bed is actually 45 degrees, at this point of time, before you touch the abdomen, you should lower down the bed to flat position, and then only remember to find a chair. Okay, don't squat down like you want to confess to your fiance or anyone. I think it's not very professional. Just request for a chair. If there's no chair, you request for a chair. If there's a chair, you take the chair and then you sit down. Only you feel for abdomen. And then after you press abdomen, as usual, palpation, palpation, and then check for liver, check for kidney, check for liver, check for spleen, and check for kidney, and then check for ascites. Kidney is something that we may want to leave it the last, ballot the kidney. But after we finish ballot the kidney, some people will always forget, including myself, sometimes I also forget to auscultate the abdomen first. Okay, remember to auscultate the abdomen after you finish ballot the kidney. After the palpation is done together with the percussion, you have to palpate, you have to auscultate the bowel sound as well as any bruit. Sometimes patient got hepatomegaly, you want to check for any hepatic bruit, splenomegaly, whether there's any splenic bruit. Okay, and don't forget that if this is a renal station, you must also listen for the kidney area to, I mean, it's just almost near at the umbilical level, left and the right side, and just to hear for any renal bruit. Some patient can come up just the renal bruit. For example, those that Takayasu arteritis, the finding the carrier is actually the renal bruit. It's possible. Okay, so remember to hear for the bruits. Then after that, usually before I go and touch the patient leg to check for pedal edema, at this point of time, I will ask patient to sit up. I will ask patient to sit up, only then I examine the lymph node. Okay, examine the lymph node over the neck generally. And at this point of time, I may also want to take out the patient, ask permission and take out the patient's shirt to look at the back, to look for any spider nevi, any scar, any deformity, any tattoo especially. Sometimes they hide only one tattoo at the back. So this is generally, I feel, is a bit safer for me to do that, because if I tend to check the lymph node and check the patient back before I proceed with the abdomen, I worry that time may be a bit limited and I may have lost myself. So I usually try to get all the positive finding. Only then this one is chill. Like just want to check any lymph node or any additional thing. Then I will only check the back and also the lymph node. Only then I will go and touch the patient leg, look at the patient, any pain and any edema. Then I will wash my hand again, and then I will say thank you to the patient and close up the patient, and I will look at the examiner. I say I would like to end my examination by mentioning all these things. Okay, the vital sign, the orifice, PR, fundoscopy, okay, urine dip, or sometimes you may want to offer some targeted examination. Sometimes you may also want to this is just more on master student. Usually master they like to hear about this. Also want to take some history regarding this and this. But generally our MRCP we don't do that. We just examine. Examination means examination. Okay, so presentation, there is no right or wrong way. So usually we can present like what we used to learn in medical school, or you can present it in the so-called professional way. You state the diagnosis upfront, and then evidence by your positive sign and your negative relevant sign, and followed by you mention the patient functional status and complication. There's no right or wrong. Okay, choose the one that you are most comfortable. Certain scenario, if you practice a lot, certain scenario to me like renal abdomen, I will go by the renal abdomen template, because if I go by the peripheral up to the end, sometimes I have compared both. I feel that the peripheral, when you mention examine peripherally up to the point that you mention the diagnosis and your causes, things like that, it costs about 2 minutes. But if you present using the renal template, I feel that it's almost 1 minute plus. And this presentation, if you present too long, like 2 to 3 minutes, imagine how much time you left for examiner to ask you about the investigation and management. If you lack on that time, for example, just 1 minute or 30 seconds, they cannot really ask you a lot of questions, and the clinical judgment you may not able to get full marks. That's why I feel like presentation should be short, concise. At the same time, you need to really mention all the important things. And to me, when unsure of my diagnosis, I always go back to classical style. Just to share my last station, I mean, last time my abdomen station was actually a case of thalassemia, but it's not actually not obvious. The face doesn't look very obvious like a chipmunk faces. It's very adult, about 40 to 50 years old uncle. And then generally the first look of it, the hand got some gout feature, you know, there is some gouty profile there, which is a bit weird because I don't not expecting rheumato station in the abdomen when I go in, but I still just examine and I don't find any obvious stigmata or chronic liver disease, because I know that it can be abdomen, it can be renal, or it can be hemato. So I'm thinking that okay, there's no stigmata or chronic liver disease. So what's next? Is it renal? Then I check very hard to look for any fistula, any IJC scar, any parathyroidectomy scar, any feature to suggest chronic liver, chronic kidney disease. Unfortunately, also no. But when I examine the abdomen, there's only hepato and splenomegaly. So at the point of time when you want to turn the patient to check for shifting downwards, things like that, I will usually, when I flip ask the patient to lie at the right lateral position for a while before I tap again, I percuss again to check for any shifting downwards. At that point of time, usually I will screen for any BMAT scar. Sometimes it's important because if a patient is a hemato kind of patient, like myeloproliferative patient, they will have a BMAT scar. So usually I will check for sacral edema. At the same time, I will just ask patients, sorry, just want to look a bit lower. And then I will check whether there's any BMAT scar or not. Okay, this is something that not many people do. But if let's say there is, then it will give you some clue. It will be very helpful. But this patient, unfortunately, when I check everything, also nothing, just hepatosplenomegaly. Okay, then I start to realize that okay, I don't know which approach that I should present this patient. I only mentioned the positive sign, so I still follow the classical way. I present from peripheral and then go to the abdomen, and then I notice the patient is also pale, so I'm committing myself this is a hemato with some form of pseudo gout or some form of gout, you know, secondary cause of gout. So this, I think that it may be due to chronic rheumatic disease. That is also, I feel there's a bit of tinge of jaundice as well that time. This is only after I finish almost examination and then feel for the lymph node over the neck, and I accidentally saw the eye a bit yellow, just very tinge. So I was like, okay, I commit myself, this is a thalassemia. So true enough, I mentioned that my differential diagnosis is chronic rheumatic anemia, and subsequently the examiner hints me to what is the homogenous causes. When I mentioned thalassemia, the examiner should have asked me everything about thalassemia. How will you manage this patient? How will you investigate things like that? So sometimes it's a bit unpredictable, I would say. But generally, if you follow your approach, you won't lose yourself. You will still remain calm. Okay. So okay, let's go to presentation of hepatobiliary. So generally, if you don't want to present like a medical student, or I mean, to me, there's not wrong at all to present like a medical student, because when the examiner marks you, they usually will mark you based on your physical examination. What are your positive signs? Only then the component of diagnosis and differential diagnosis. Okay, so if you are not sure of diagnosis, I won't recommend you use the professional style, because if you mention the diagnosis upfront wrong, certain examiner will not hint you anymore because the diagnosis is wrong. All your clinical sign, they will not give you marks. Certain examiner, they tend to drag you back. Okay, sorry, maybe not go to diagnosis first. Tell me what do you find. So certain examiner will help you to actually score from the sign first, and then only the guide you on differential diagnosis. To me, if this is very clear cut and want to save time, I can present like that. So this this patient, this man have my diagnosis, my working diagnosis for this man is actually a chronic liver disease, evidenced by stigmata of chronic liver disease, which you want to mention that, for example, which include polyonychia, hysteresis. Hysteresis usually signs of decompensation. I will mention like loss of axillary hair and gynecomastia, or even and there's also spinal nevus seen at the truncal area. So, and in terms of complication, I will mention he have evidence of portal hypertension. That is clinically there's ascites with positive shifting downwards, and there's also dilated abdominal vein, and I can also appreciate that splenomegaly. Clinically, he's in a state of decompensation because there is jaundice, there is a hepatic hysteresis, and but otherwise there's no pedal edema, and there's no obvious bruises seen. Additionally, for example, this is something I always force myself to mention. You must mention something that you won't be mentioning routinely according to your own template. So I always put something called additional. You want to mention anything else that you want to mention. For example, there's tattoo mark that is needing injection mark that you want to mention, because that can give you hints when you want to offer etiology, when you want to prioritize the etiology. Okay, so this is generally how I present if professional style for hepatobiliary. bear in mind that you can still follow the usual conventional way, which is not wrong. Okay, so how about liver transplant? Not common, but still possible in our Malaysian setting, because there is a few patients that can come for exam as well. So you may want to mention that, for example, this patient have a rooftop scar and also that stoma bag. Okay, so you may want to present this patient as, sir, I think this patient have a working diagnosis of end-stage renal disease with the presence of stigmata of chronic liver disease and hepatomegaly, and he is currently is supposed to most likely have post liver transplant evidenced by the rooftop scar or modified Makuchi scar, things like that. And in terms of complication, he have no ascites, no dilated abdominal vein to suggest capillary and unable to appreciate splenomegaly. Clinically, he is not, there's no signs of decompensation, there's no jaundice, fluid overload, hepatic esteresis, or bruises to suggest coagulopathy. In terms of immunosuppression complication, he appears Cushingnoid, and however, there's no gum hypertrophy. Additionally, I also found out there is a scar to suggest colectomy, and there's also a stomach bag, for example, which may suggest ileostomy based on the location. I want to offer my etiology for this patient as possible primary sclerosing cholangitis with underlying Crohn's ulcerative colitis, for example, just like that. Okay, so let's go to the discussion. Discussion, basically, we just want examiner to score us on the clinical judgment. And what we should do is actually prepare a very good investigation and also management workflow for yourself. This is how I generally prepare. I tend to separate my workout and also the management into a few domain, because sometimes when you mention, like for example, in terms of investigation for diagnostic, then I'll mention this. So for example, when I mention a certain domain, I will tend to give me a few more seconds to think what else I need to add on, or what else I need to mention. So I feel it's better this way, but there's no right or wrong. You can just mention that FBC, RP, RFT. But if you mention all that, you must justify yourself why you want to take the test. You cannot just mention, I will take a basic blood test including FBC, RP, RFT, things like that. No. You must mention that I want to take full blood count to look for any evidence of anemia, liver function to as well as coagulation profile, and to correlate with clinically to calculate for Charles-Bill score, things like that. So if you want to mention a test, you must mention a justification. Okay, so for me, it's easier to mention in terms of investigation. For diagnosis, I will order a liver function coagulation to calculate this. Outside abdomen to look for cirrhosis and ascites. I will perform a diagnostic and therapeutic peritoneal tapping and send for this. And in terms of non-invasive test for cirrhosis, I may want to calculate the FIB4 score, fibroscan. Okay, and in terms of etiology, I want to take a hepatitis screening, alpha fetoprotein multiphase CT, and also some malignancy screen. I mean, if I'm suspecting a secondary causes, blood culture, serology, all those if suggested infective causes, autoimmune screening, iron study, and also lipid profile, and also the copper screening, and echo as well if I'm suspecting this is more like hepatic congestion, right heart failure. And if the diagnosis is uncertain, I may want to counsel patient for invasive tests, which include liver biopsy. And then if you are dealing more to myeloproliferative or lymphoproliferative disease, you may want to mention additionally about the full blood count as well as BMAT and the biopsy. Okay, so in terms of complication for liver cirrhosis, you may want to mention that I may want to consider taking serum ammonia or also CT brain to exclude hepatic encephalopathy, make sure there's no bleeding. For varicose screening, I want to do a OGDS with or without varicose branding. For SPP, want to make sure that patient has no to check for the cell count and also the culture. For hepatorenal, want to check for kidney function and also the UFAM as well as ultrasound. Just mention a simple. You don't need to mention all this. Basically, you just mention a bit here and there. Then it's definitely enough. Management, I also tend to divide into a few domain, because I feel it's easy to mention this way. And if you cannot remember anything, just mention that. So in terms of management, it will be multidisciplinary team approach, focusing on patient education and counseling. Full stop. So you give yourself 5 seconds actually to think about what you're going to say next. In terms of non-pharmaco, I'm going to advise patient to stop alcohol, avoid any hepatotoxic medication. I will make sure the fluid control is good, and also refer to dietitian for low sodium and high protein diet. In terms of pharmacologically, start patient on laxative. For varicose, want to do this and that. I won't go through all in detail because I feel it's a bit you all can go through yourself. And for non-pharmacologically and for surgical causes, for example, may not to subject patient for annual OGDS, HCC surveillance, SPP prophylaxis. If it refractory causes, I may need to consider about advanced therapy like TIPS or even liver transplant. And generally, vaccination is something that we can mention if you cannot think of anything. Generally, any patient with immunosuppression, even if it's a renal transplant patient, liver transplant patient, or any respiratory cases, you should mention vaccination. Huh? Remember vaccination. Okay. So for renal abdomen, what I usually do is actually this is the approach that I feel very useful because it saves time. At the same time, it won't miss out any important clues for any renal abdomen. Any renal abdomen, regardless how complicated it is, got this IJ, got this Tenkos which is removed, got multiple scar here and there, it's still okay. Just follow this approach, and I feel is you will cover everything nicely. So I will mention that, sir, this patient have evidence. I think my working diagnosis is a end-stage renal disease on renal replacement therapy. The active mode of renal replacement therapy would be the functioning right AV fistula over the cubital fossa, for example. You want to mention like that. If you are confident, you want to mention bacocephalic, uh, bacobacillic, all those things. But generally, I don't recommend to mention that because some they may not be fistula, some may be graft, and you cannot differentiate. So just mention AVF, okay? And for example, the active mode for dialysis is the active mode of renal replacement therapy would be the right evidence of right functioning AVF. That is probable trill, and there's also buried hurt. And at the same time, there's also evidence of to suggest there's also, for example, this is a renal transplant because to me, functioning AV fistula a bit too easy for exam. So active mode of renal replacement therapy would be would be renal transplant evidenced by a right Rutherford Morrison scar. Okay, and there's also, for example, to make things complicated, there's also a functioning right AV fistula, okay, with a palpable trill and this and that. For regarding the past mode of renal replacement therapy, there's multiple scar over the neck to suggest previous tunnel catheter over the internal jugular vein, and there's also, for example, a midline laparotomy scar or even a transverse incision to suggest previous Tenkov insertion. In terms of complication for end-stage renal disease, clinically he is not anemic, and there is no parathyroidectomy scar with or without autoimplantation of the deltoid or even the bicep to suggest mineral bone disease. Or you want to mention end stage is basically anemia and also the MBD lah. In terms of the complication for dialysis, there's no clinically he or she is euvolemic, no sign of uremia and no signs of infection. Okay, in terms of complication for immunosuppression, clinically he is Cushingnoid, and there is evidence of gum hepatopathy, for example. However, there's no tremor, there's no fine tremor or any alopecia to suggest this calcineurin inhibitor toxicity. Sometimes skin lesion is also important, very important. Additionally, you may want to mention something important. For example, patient the abdomen parambilical got a lot of this insulin injection scar, the lipodystrophy scar. So you want to mention that I also found that there is multiple lipodystrophy evidence of lipodystrophy to suggest possible diabetes. And you want to check the patient back when you sit up the patient to check for lymph node, check for the back. At the same time, also look at the groin area to make sure that you don't miss any scar to suggest nephrectomy. Okay, for example, some patient like adult polycystic kidney disease, they may have a nephrectomy to give space for the transplant kidney. Okay, and next is to offer your cause. The commonest cause for end-stage renal failure in Malaysia, okay, 60% is due to diabetic nephropathy, 20% is due to hypertensive nephropathy, remaining 10% is actually due to drugs, particularly at the NSAID induced nephropathy, and commonest cause of hereditary causes would be the adult polycystic kidney disease. Remaining about 5% is due to GN, including lupus nephritis and some autoimmune disease, and the remaining probably about 3% is due to post-renal causes like obstructive uropathy, posterior urethral valve, and all those rare causes. Okay, so basically this is how you generally present. If let's say you found that it's palatable kidney, your etiology, then you must put the adult polycystic kidney first, and you can also put diabetic because diabetes can also cause enlarged kidney, right? So this is, I feel, very useful table when I prepare for my exam. You must always prime yourself that if you find one palatable kidney, what are the possible differential diagnosis? If you feel both palatable kidneys, what are your possible differential diagnosis? But please bear in mind that if you feel a palatable kidney, usually you may miss it as misinterpret as a hepatosplenomegaly. That's very common when even at the MBBS level until the MRCP level. So make sure that you don't you don't present the bilateral kidney as hepatosplenomegaly. So you must really feel the upper margin of the mass properly, whether you can feel there is a gap or not. And then when you ballot the kidney, make sure you really push from the down and feel whether there's any palatable or not. Okay, so it's important to differentiate these two. So if it's a palatable, if you are talking about adult polycystic kidney disease, these three are the one that hereditary and tend to cause both kidney to be enlarged. Can be Wharton Hippo-Lindau, can be tuberous sclerosis complex. Next is the diabetic nephropathy, infiltrative amyloidosis, bilateral obstructive uropathy, and bilateral renal cell carcinoma. Unilateral causes, you may want to mention something about more acute like hydronephrosis, pyelonephrosis, or post-biopsy perirenal hematoma, adult polycystic kidney disease with asymmetrical enlargement, or adult autosomal recessive. Those younger presentation, they may only have one bilateral kidney, or most of the time renal cell carcinoma can just have only one side. Generally, those cancer patients, they are a bit ill. Usually, we won't see them in exam. We tend to bring more stable patients like adult polycystic kidney disease. And bear in mind that if patient have a contralateral nephrectomy scar seen, this can be due to the compensatory renal hypertrophy. But you don't want to mention that before you mention the adult polycystic kidney disease. Like I mentioned, sometimes the polycystic kidney are very huge. You cannot put a transplant kidney just superficial anterior to it. That's why you still have to make space, and therefore the commonest, you still need to measure adult polycystic kidney before you measure about this. Okay, so etiology, again, for the renal abdomen, I will have my own template. Everyone can have your own template as well. I mean, there's no right or wrong. Like I say, you can just measure everything according to what you are used to. I want to mention about renal function and also blood gas to check for any acidosis, urine, FEME, quantify the protein. Etiology wise, I want to check for diabetes, hepatitis, autoimmune, post-renal causes with the ultrasound KLB and with Doppler biopsy, things like that. Anemia, complication is basically anemia, mineral bone disease, and also the cardiovascular risk. Management is non-pharmaco and others. I won't mention all that thing, but basically this is something that if you have my notes, the book that you all order for me, you all can read through and can practice the flow with it, because I feel it very helpful. Generally, for example, renal transplant, they may ask you a bit more particularly on the transplant. So let's say patient have AKI, what is your workup? They'll give you some hint. So you will say, so this is the AKI in the post-transplant patient. You will want to see that, okay, want to take a therapeutic drug monitoring for the calcineurin inhibitor, make sure it's not toxic. Want to check for whether there's any evidence of antibody-mediated rejection by taking an anti-donor specific antibody. At the same time, also want to check urine FEME to look for any proteinuria, ultrasound QB to look for any stenosis or any graft stenosis basically. Okay, and generally this is the style okay. So for thalassemia, this is the third component of the abdomen. So thalassemia, you need to know this is also another template that you can use, but if you don't want to use template, you want to present from the peripheral to abdomen and then give your final diagnosis, also okay. Thalassemia, if it's very clear-cut thalassemia, I can present like, okay, sir, I think this patient has working diagnosis of thalassemia, evidence by thalassemic phases, clinical anemia, as well as tinge of jaundice. Okay, in terms of complication, he or she has features of extramedullary hemopoiesis, which is hepatosplenomegaly, thrombosis, with or without scoliosis. There's also evidence of hypertransfusion, which include skin pigmentation, and also I noticed there is some sugar finger prick mark to suggest diabetes. And there's also features to suggest chronic liver disease or hypogonadism, which include loss of axillary hair and also stigmata of chronic liver disease. Clinically, remember for thalassemia, if you think this patient has thalassemia, usually some extra thing that examiner expecting us to do is to auscultate for any loud P2. Okay, it's very important, because if it's thalassemia, it's very clear-cut thalassemia, examiner tends to ask you more about complication. So this is something that we need to mention. Okay, means after you finish your abdomen examination, you feel for the check for the lymph node, everything, and then feel for the pedal edema. You need to put your stethoscope at the pulmonary area to listen for any loud P2, because if there's a loud P2, then there is features to suggest right heart failure or pulmonary hypertension, which is quite common in thalassemia. One of the complications we should mention. And then arthropathy pseudogout. This is what I encounter. If I didn't know about this association with thalassemia, I think I will really miss the diagnosis of thalassemia. Okay, so one of the complications of hypertransfusion is also the arthropathy part, which is the pseudogout. Okay, so in terms of other complication like chelation, usually patient nowadays, they tend to start on oral chelation therapy instead of desfloxamine. So some patient may actually, they just hang a subcutaneous infusion pump at the bedside for you to see. If you saw this kind of patient, you know that your diagnosis is definitely iron overload patient. And you look for thalassemia phases, then this is thalassemia. If there's no thalassemia phases, then maybe you're dealing with hereditary hemochromatosis. Okay, so sometimes the peripheral examination will give you the working diagnosis as well. So other complication, in terms of complication for chronic hemolysis, I noticed that there is a chemoport, or for example, there's PICC with the patient, which may suggest transfusion dependent thalassemia. And there's also, for example, there's cholecystectomy scar or there's splenectomy scar to suggest evidence of chronic hemolysis or iron overload, okay, hypersplenism. So this is generally how I prepare myself when I present the thalassemia patient. But you want to present it from peripherally until the abdomen is also okay. Okay, depending on which one you're more comfortable. So thalassemia, usually the workup is like hemolytic workup. Usually no need to mention hemolytic workup unless you're suspecting like IHA, things like that. You want to mention HB electrophoresis, DNA analysis, full blood picture to look for target cell. And for example, complication for thalassemia is very important. You must mention diabetes, pituitary hormone screening, okay, because it can affect central hypothalamic hypogonadism and hemochromatosis. Therefore, is the keyword is the MRI-T2 star to mention to check for the heart and the liver, hepatitis screening because of regular transfusion, osteoporosis, DEXA scan, and the ultrasound abdomen to look for features of the pigmented gallstone. Okay, management wise, non-pharmaco, and others. I won't mention all these things, but generally you can see that vaccination works for all the scenario. Blood pressure control, chelation, bone protection. Post-splenectomy, you want to mention, let's say there's splenectomy scar, you want to mention prophylactic penicillin B, and also make sure the vaccination is up to date. And surgical causes, these are the other things. Hematopoietic stem cell, this you need to read a bit what are the criteria, but generally it's a high transfusion requirement. And then there's a few other criteria, which I'm not going to talk about this. So the fourth one is the hemato one, the myelo or lymphoproliferative disease. Usually I won't present based on this template, but if you want to follow this template, it's also not wrong. This is something that just prepare myself. I know that what are the things I should mention under the complication. For example, this is a middle age or young age or elderly man with most solid with the working diagnosis of this because of present anemia, hepatospleno, or lymphadenopathy. So you must mention these two. And if you're committed that this is a hemato station, you must also exclude stigmata of chronic liver as well as chronic kidney disease. Okay, and in terms of complication, you may want to mention about prenatal drift. You may want to check for additional thing, and you want to mention if patient got any antibiotic attached. You may want to check for to mention that any possibility of infection, and if the patient got a lot of oral ulcer and also appear to have significant hair loss or even just bowel, you may want to mention about probably recent chemotherapy. And additionally, you may also want to check for any chemoport and also PICC. Causes, if myeloproliferative is simple, just these four usually: polycythemia, CML, ET, or MF. Lymphoproliferative is usually chronic lymphoma or lymphocytic leukemia. Okay, Hodgkin or non-Hodgkin. Okay, so in terms of the investigation, this is the approach. You don't need to mention in detail. PBM want to look for leukoerythroblast picture as well as blast cell. LAP if you want to differentiate between leukemia reaction or true leukemia. BMAT is something I would spend some time to mention because BMAT actually there are few components. Do an experience amplifying cytogenetic to look for chromosomal typing, immunophenotyping to look for cell type differentiation, molecular study for prognostication, for example, JAK2V617F, things like that, and links biopsy and also CT staging and PET scan. Complication wise, want to make sure that patient to screen for tumor screening, tumor like for example LDH, uric acid, renal function, on the full septic workup, and also if let's say patient have prenatal drift, things like that, you may want to offer a CT brain, but generally very rare, like you don't need to mention also, never mind. So supportive and specific in terms of management, multidisciplinary team approach. For example, tumor lysis prophylaxis, you may want to offer hyperhydration, correct the electrolytes. You may want to consider starting the allopurinol, respiratory case, sepsis, contact strict hygiene, things like that. Specific one, if let's say examiner asks you, you may want to know a bit in detail. For example, like CML, just a first line treatment like tyrosine kinase inhibitor, for Philadelphia positive, or consider hematopoietic stem cell. Polycythemia vera, you want to consider venesection, like what we discussed in the last session, how we manage polycythemia vera. And for example, ET, essential thrombocytosis, aspirin and cytoreductive. MF is also rhizonotinib and also stem cell. Okay, so this is just a rough idea. And occasionally you may have some rare condition. If they don't have patient, suddenly the patient cannot come. The last minute drag one gynae patient to you. It's possible. Okay, I have my experience. My first attempt was a gynae pathology. Okay, so but that time, surprisingly, I got full marks for this. I was not anticipating this kind of scenario, but that was really the rarity. There's a very well-defined mass at the suprapubic region. There's no hepato or splenomegaly, no stigmata of chronic liver or chronic kidney disease. There's no BMAT scar. Clinically, it's pale, but there's no evidence of jaundice to really suggest hemolytic hematocause. So eventually, I committed that this is a gynae pathology with the evidence of suprapubic mass. So the examiner expecting me to mention UPT. Actually, the patient looks like 50 plus already. But anyway, the patient examined what the patient, the examiner actually asked me what are the differential diagnosis. So I mentioned about can be gynae causes like fibroid, benign causes like fibroid or adenomyosis. Malignant causes can be due to like uterine cancer or ovarian cancer or even cervical cancer that spread to the other region, or even bladder cancer. So you must know the location. Can be bladder cancer. And GI I didn't mention, but they didn't hint me as well, but they anticipate me to talk about UPT. And let's say you are encountering an ileal mass. Okay, that's right, ileal fossa got some palpable mass there. And you may want to offer this few differential diagnosis. That's why to me is always expect the unexpected. Then you will feel comfortable regardless of what scenario you encounter. Okay, so generally you can talk about hemato like lymphoma, genital urinary causes. If female want to talk like ovarian, or even kidney, usually you won't miss it. Transplanted kidney got a scar, very obvious scar. Like for example, in male, you want to talk about undescended testes. Very rare, not commonly you will have this kind of scenario, but something that you need to be aware. Sometimes it can happen. So respiratory system. Okay, so let's go to respiratory system. Usually the possible scenario is only these four. Okay, so this four is the main idea that will usually come out in the showcase. So many years the exam scenario is almost always the same. So these four are the possibility. First, you are talking about CRAPS. Okay, CRAPS with or without clubbing. Usually we have some clubbing, mild clubbing, significant clubbing. Then there is capitation, be it upper zone, middle zone, or lower zone. So you want to differentiate between this is a bronchiectasis or lung fibrosis. Okay, this is the first possibility. Second possibility is may or may have a tracheal deviation, and there's a reduced breath sound over the lower zone, either side of the lung, and you will need to identify whether this is a collapse consolidation or pleural effusion. And therefore, it's also very important for you to check for any chest tube scar to make sure that you're not missing a recurrent pleural effusion. Okay. The third possibility is usually the scar. Scar is the common, perhaps the commonest. For example, patient have a lateral thoracotomy scar. You're not sure whether this is a pneumonectomy or lobectomy. That's one possibility. Second possibility is you don't find a thoracotomy scar, you only found a three triangle kind of scar to suggest a video-assisted thoracoscopic surgery, or sometimes it may just be chest tube. Okay, so the fourth possibility is the very normal abdomen, very normal respiratory system, which is like the lung looks very normal to you, don't find any obvious clue. Bear in mind that a patient without any sign can come out in the exam as well. It's a perfectly normal respiratory examination. It's also possible to come out in exam. Okay, but sometimes before you come to a conclusion that this is normal, you should exclude the abnormal. Therefore, I also will talk about if you feel like this patient is everything looks very normal, you need to take a step back and really think whether this is normal. Okay, so go to the first one. Before that, just some tips. Peripheral screening is very important. Sometimes the screening criteria for respiratory station when you stand at the end of the bed is to ask patient to cough. Okay, make sure patient cough out and see whether patient can stop the cough or not. Like bronchiectasis kind of patient, after cough once, it will many times. Okay, then you know that very copious. And this may suggest bronchiectasis. And peripheral screening at the same time, you want to check the hand for any rheumatostigmata. And if patient looks frail, looks cachectic, you are thinking more to like infective causes or malignancy, like for example TB. And sometimes this tiny little thing that stick on the patient's chest may also help you. The fentanyl patch. If you see that, then you know the analysis is definitely lung cancer already. Most of the time, it's lung cancer. Okay, and if there is some evidence of infective sign like IVDU injection mark or tattoo, you may want to offer your priority as a TB. Tuberculosis is very common in Malaysia. And sometimes you may not find anything, but you notice patient looks a bit unusual, right? Syndromic a bit. The first thing you want to rule out is a muffin. Sometimes some other thing like catatonic, things like that can come out. But usually, remember that this is respiratory station, you are focusing on respiratory. You not really want to check for anything. So if it's syndromic, then yes, this is syndromic. You want to, if this is muffin, and there is bilateral thoracotomy scar, you are thinking more to bulectomy or any chest drain because of recurrent pneumothorax, right? So you are thinking all these things. And for respiratory station, don't ever miss to examine the trachea. It's very important, very crucial. Sometimes you may fail the station if you did not examine the trachea under the physical examination. Meaning the physical examination, the examiner can give you 0, very emotional, because trachea is very important in respiratory system. Okay, whether it's deviated or central. So a lot of people say a lot of things like you should, after you examine peripheral, you should straight away go to the back to examine the patient lung, and then only then you go to the front, only then you check the peripheral like pededema, or you check the lymph node, things like that. Different people got different style. There's no right or wrong, but to me, it's still still the safest way is actually to examine the peripheral, then go to the anterior chest, and then go to the posterior chest. How I do that is you must time yourself to examine peripheral as well as anterior chest to finish this in 2 minutes. You must finish anterior chest in 2 minutes. Let's say you didn't manage to finish the anterior chest by 2 minutes, you should force yourself to go to the back as possible, as fast as possible, because most of the sign is actually at the back. But please bear in mind that if you detect something in the anterior chest, then when you go to the posterior chest, it's mainly to confirm your finding. But let's say you didn't find anything in the anterior chest, then you really need to, stay even more calm, because most of the time, maybe your finding is only at the posterior chest. Okay, so how I examine the anterior chest, examine the peripheral hand, check for eye, congenital pallor, jaundice, and then I will also look, I will at this point of time I will check for the tracheal deviation, and then only then I will straight away go to anterior chest examination. I will feel, after I feel for trachea, I may feel for tracheal duct, let's say I'm suspecting obstructive airway disease, and then I go to the chest. I will start with palpation first. I will feel the apex peak if possible. And sometimes if you think this patient is catatonic and there is evidence of bronchiectasis, you may want to consider feeling both apex peak, both sides, to make sure you're not dealing with dextrocardia, because this is not a cardiovascular station. You won't routinely do that. But in respiratory examination, if patient have bronchiectasis and very significant clubbing, you really want to make sure that you don't miss a dextrocardia. Okay, but anyhow, generally you only feel the apex peak. You can feel whether it's displaced or not. To me, trachea is more sensitive. Then you feel for the, then straight away proceed with chest expansion, and then percussion, and then auscultation, and then vocal resonance. After you finish, I mean, you can up, middle, and the lower. You can do only three region, up, middle, and lower. No need to do 8 or 12 like in medical student. I think generally three level is enough for both sides. And then after that, you straight away go to the back. So I will really go to the back to examine my repeating the same thing. I will do the chest expansion, percussion, auscultation, and also vocal resonance. Only then I will examine the lymph node. You can choose to examine the lymph node first. Only you proceed with the palpation until the auscultation. There's no right or wrong way. But to me, I will want to confirm my finding correlates with the anterior examination of the chest or not. So after that, I will check the lymph node, and then after that, I will look for any other features before I feel the pedal edema. So generally, usually when I auscultate the anterior chest also, another clue is I tend to stay a bit longer at the left upper chest to listen for any loud P2 as well. Because you know that when we auscultate for the anterior chest, right, we just up 2 point, middle 2 point, and lower the lateral 2 point, right? So the upper left, I tend to stay a bit longer because I want to listen whether there's any loud P2, which may be important. Okay, so that is it. So usually it's enough time. If you practice enough, by 5 minutes and 30 seconds, you should finish your respiratory station. But if you spend too much time taking the patient clothes off, turning the patient, things like that, you feel stressed. So the idea is, if you didn't manage to examine the anterior chest by 2 minutes, you just quickly finish up and go to the back. Okay, this is the idea. And some condition is not likely to come out in an exam. For example, the extreme pneumothorax will not come out, not fair. Massive perfusion without any symptom or with just nasal polyp also unlikely to come out because they are very, very weak as well. And if you have multiple signs that you cannot explain with single etiology, just offer tuberculosis. For example, tuberculosis patient, you may find bronchial bleeding, you may find lung collapse, you may find crepitation also. Apa pun ada, maybe got some clubbing as well. Okay, you don't know what you are dealing with. Just mention etiology, those suppurative lung disease. You can mention tuberculosis, you can mention bronchiectasis, you can mention about habitating lung disease, or for example, those suppurative lung disease. Okay, you can mention all that. Okay, this is just some workflow. Generally, this is what we usually do when to check for whether patient have any evidence of respiratory distress and whether there's any scar, any signs of hyperinflation. Hansel bundle usually will not mention unless patient have, the so-called nicotine stain is very rare. But let's say got fentanyl patch and then got some topsis. I don't know whether it will come out or not. I mean, the hornus is very rare, but something that we need to keep in the back of our mind. If there's a lymph node, there's a RT scar, then it's easy. And copulmonary is also important, but generally I only screen for basically loud P2 lah. And chest expansion, this is one of the way, but to me, I want to simplify it. I will usually use this approach. This is a simpler approach to me. If you feel that the patient chest expansion is symmetrically reduced, upper and lower zone, and there is no scar, you don't find any scar at all, then you're thinking more to obstructive or restrictive lung. So if obstructive, you're thinking more to bronchiectasis, COPD, or asthma. Restrictive, you're talking about lung fibrosis. If let's say this is a symmetrical reduced chest expansion with evidence of thoracotomy scar, you need to think about all these things. It can be due to bulectomy, pyrrectomy, lobectomy, okay? And usually pneumonectomy will be asymmetrical, cannot be symmetrical, okay? So it's either lobectomy or smaller procedure like bulectomy or pyrrectomy. It can also be due to bilateral or unilateral lung transplant. Usually, bilateral lung transplant can be bilateral thoracotomy scar, or there is a clamshell scar situated below the breast, okay? So, but it's quite rare in our Malaysia. In terms of asymmetrical chest expansion, let's say just one side reduced. You want to check whether there is any scar. If there's no scar, then you're dealing with lung collapse versus consolidation, effusion, or this can be bronchiectasis versus fibrosis, which is very common, can come up, okay? But sometimes fibrosis and bronchiectasis are symmetrical. Most of the time are symmetrical. Occasionally, they may have some tractional, and then one side, the trachea will be deviated, and breath sound also reduced one side as well. It's possible, okay? If there is an asymmetrical chest expansion with evidence of scar, then you need to think hard for all these things. Pneumonectomy and lobectomy. And usually it's the upper lobectomy that causes the tracheal deviation, okay? Usually middle and lower, the trachea will be central and the breath sound will be equal or slightly reduced, but almost the same. Pneumonectomy, breath sound will be absent. And recurrent pupil effusion is also possible. They will have some multiple chest drain scar. Okay. And lung reduction surgery is possible for those chronic COPD patient. Okay. This is also another possibility. So first is actually how you differentiate between bronchiectasis and fibrosis. But generally, both of them will usually have clubbing and usually have crepitation, be it fine or coarse crepitation. If it's a very clear-cut fine crepitation, then it's almost always fibrosis, okay? If it's coarse crepitation, usually it's a bronchiectasis. But bear in mind that eventually all the patients with fibrosis will develop end-stage bronchiectasis. So eventually all the late-stage fibrosis patients will also have coarse crepitation because they already developed bronchiectasis, but the primary etiology is still fibrosis. So sometimes the crepitation may not able to tell you whether it's fine or it's fine, it's definitely fibrosis. But if it's a coarse crepitation, you cannot really tell whether this is bronchiectasis or fibrosis. So there's a few differences that you can differentiate. First is when you stand at the end of the bed, ask patient to cough. If let's say the cough is really chesty, and this suggests more on bronchiectasis. If it's just a very dry cough, then you're thinking more to fibrosis. And second thing is the crepitation, like I say, cause usually late stage, difficult to tell. But the clue is actually these two. After with coughing is something very subjective, I feel, 50-50. Sometimes you escort it at a particular region after you cough. You escort it with another region, it does not alter with cough. So actually it's alter with cough or not, you're also not sure. So sometimes it's very opportunistic. So I tend not to use the alter with cough as a guide for bronchiectasis or fibrosis. Unless it's very clear cut, it's altered, then this is bronchiectasis. To me, it's not very useful, but to me, the end inspiration is the one that gives me an idea. So notice when the patient breathe in and out. Let's say patient breathe, you hear the craps. Craps can be started at the early inspiratory, mid inspiratory, or late inspiratory, and then followed by expiration. So the clue is actually the end of the inspiration before the expiration. Let's say you listen the craps, it's actually very loud to begin with, and then towards the end, you don't right before the patient exhale, you cannot hear the claps anymore. It's very I mean it kind of tuned down because all the small area has already dilated, right? They cannot open up all the smaller area already, all the large being opened up. So that's why towards the end inspiration, the capitation will reduce. So you will hear the capitation, then like nothing, and then only patient expire out. If you manage to appreciate this pattern, then usually this is bronchiectasis. Okay. However, if the crepitation you hear all the way loud until the end inspiration, sometimes even extend until patient expired, or just before the patient expired, if it's still loud, equal loudness, then you're thinking more to fibrosis. Generally, I feel this is a more objective kind of things to guide you. But having said that, you still need to correlate all these things together. Second possibility is a collapse consolidation versus pleural effusion. So usually what is your finding? Your finding is usually there's no scar unless there's some chest tube scar in recurrent effusion. Let's say there's no scar. Usually what you find is generally there's reduced chest expansion, downers on percussion, and also reduced vocal resonance. And this is either the right lung, right lower zone, or left lower zone. So how do you tell this is a collapse consolidation or this is a pleural effusion? So you really need to make sure that you give the correct diagnosis. So the difference is actually the trachea. Again, trachea is very important. If you manage to elicit that there's tracheal deviation to the ipsilateral side, then this is most likely a lung upper zone collapse with elevated diaphragm. That's why you when you auscultate the diaphragm, I mean at the lower zone is reduced breath sound, reduced vocal resonance, and the chest expansion also reduced. Okay, if let's say there's contralateral deviation or no deviation, usually it's pleural effusion. Okay, and how about bronchial breathing? If you're able to appreciate that it's bronchial breathing at the upper zone, usually then you will know that this is a collapse. Okay, but let's say the bronchial breathing is only present or absent, then you know that this is pleural effusion. Okay, how about vocal resonance? So vocal resonance is also important because if you are dealing with consolidation, you should able to hear that is usually there is some mass that compression at the upper zone and causes the collapse. Okay, or there's a mass in the middle zone. Okay, so usually you will hear increase in vocal resonance at the upper or middle zone, and when you auscultate at the lower zone is reduced and the trachea is deviated ipsilaterally, then you know that this is not just collapse, there is also consolidation because there is increase in vocal resonance. Sometimes it may just be lung collapse. And another thing is actually if pleural effusion, then it's very clear cut. Vocal resonance and also breath sound is reduced at the level and also below the level effusion. Okay, so these are some very useful clues to actually tell you between these two. Next is a scar. Can be chest tube scar, can be warts, can be unilateral thoracotomy or bilateral thoracotomy. So for warts and unilateral thoracotomy, I want to mention this. So basically, you can start with smallest thing first when you want to offer a differential diagnosis. What are the etiology? What are indication to do that? You can mention the smallest one being the putting in just one needle for biopsy, to wedge resection, segment resection, decortication, remove the bullae, remove the whole loop, or remove the pleural. Okay, so you can start from the smallest to the biggest or biggest to smallest. This is usually we need to have a few differential diagnosis before we go exam. Okay, for unilateral thoracotomy, same again, go from the smallest to the biggest, decortication, bulectomy, lobac or pneumonic, lung volume reduction, pyrectomy. Extrapleural pneumonic, you can forget. I think it won't come out in our exam. And bilateral thoracotomy, you want to make sure you don't miss a clamshell scar. And anterior mediastinotomy is very old. I don't think it's possible to see it in this era. But some elderly may have the TB biopsy at the mediastinal lymph node. They may have this scar. Supraclavicular is a phrenic nerve crush, which is also like classic already. Now we don't really see this kind of patient anymore. Posterior thoracotomy is the one that also for TB, old TB, but it's also very hardly seen. Usually they will have a severe chest deformity. Okay, so this is the fourth possibility. If you look at the chest and it's almost normal to you, so you need to think that can this be obstructive lung disease with no bronchi with just prolonged expiratory phase? and there's also evidence of hyperinflation. So you need to make sure that this is not obstructive lung, number one. Number two is maybe you miss out the trachea deviation. Maybe the trachea is not central, and maybe the breath sound is actually got reduced over one side. So you may want to examine again, okay? Or when you listen, you really listen hard for it. And sometimes maybe just the crew is just want to test about scar and you miss the scar. Therefore, you think this is a normal respiratory examination. So you must make sure you check back the scar again, because like for example, lobectomy with a lateral thoracotomy scar, this patient can have no other feature, no other significant sign. Maybe has a bit of clubbing, with or without clubbing. Tracheal is central in middle or lower lobectomy, and usually it's deviated in the upper lobectomy. But generally, if you encounter this like lower or middle lobectomy, usually you found nothing other than the scar. And the scar sometimes can be very faint, especially the skin is it's either too bright or too dark, cannot see the scar. Okay, so may want to check again. And sometimes maybe your diagnosis is wrong. Okay, maybe there is something that you miss peripherally. We consider back and think. But let's say you really cannot find anything, then maybe you want to mention, can it be obstructive lung? If not, then you can mention that, sir, I do not find any obvious uh, clinical sign for this patient. I think this patient have a normal respiratory examination. You can mention that. If the examiner want to help you, they will say, do you sure this is normal? Do you want to examine, like for example, the trachea again? So then you know that, okay, definitely the trachea is deviated, huh? So sometimes it takes a bit of luck as well. Some examiner just purposely psycho you. So is this really normal? Then you say, yes, this is normal. And the examiner actually this is normal examination, but you, for example, you're not sure, then you say, oh sorry, I'm not entirely sure. Then the examiner may not able to help you. Okay, so next is actually to complete examination. How do you complete examination for respiratory station? Generally, you want to complete examination by all the observation chart, peak side, peak foil, okay, and also sputum port if not mentioned. And then the targeted examination is something that is useful to mention, okay. So targeted examination is something like, for example, if you think there is a rheumatological stigmata, you may want to mention that. Okay, and then if there is you notice some neck swelling, because sometimes period infusion you want to rule out the cause, so sometimes you may want to offer to check for neck, to check for thyroid, any goiter, and also check for urine dip as well, because sometimes if it's just unilateral period infusion and you don't find any obvious lung pathology, unilateral one-sided effusion, it can be due to lung pathology, can be due to, for example, uh, parapneumonic effusion, it can be due to malignant effusion from the cancer, okay, or it can be due to non respiratory causes like, hypothyroid, nephrotic, this thing like that. So this is something that you may want to offer if it's relevant. If it's not relevant, no need to mention. Okay. So next is actually okay, just skip. So next is actually how we're going to answer the examiner how to investigate and manage. Okay, so want to take a blood gas, lung function, X-ray, HRCT, diagnostic tapping if you got fusion, bronchoscopy, lung biopsy, and to identify the etiology, you may want to mention that want to check for sputum culture, echo, right heart catheter if that's got pulmonary hypertension, CT, PET, specific like connective tissue. So this actually very, how would you say, very fluid. Just mention what is relevant, depending on the diagnosis. And management, non-pharmacal, there's few important things that we need to mention for non-pharmacal. First, like I said, our mantra is MDT, focusing on patient education and counseling. Advise patient to stop smoking and remove the triggers. Let's say this is obstructive lung disease. Pulmonary rehabilitation, OT, PT, oxygen therapy, dietitian, optimize the nutrition, vaccination, everything is very ideal. Just mention this. And pharmacologically, optimize the underlying condition. Consider mucolytic, expectorant, bronchodilators for those with obstructive lung. Antibiotic like bronchiectasis as for anti-inflammatory purpose. Steroid for exacerbation. And also for ILD, there's also a role. Let's say you are thinking more to inflammatory subtype, then there's a role to give steroid. For fibrotic subtype of ILD, then you're talking about antifibrotic like pirfenidone or nintedanib. Okay. And specific one will be include like chemotherapy, biological therapy, like cystic fibrosis is not common in our population, but in UK or in Middle East, you might want to mention about CFTR modulators. Okay, there's combination therapy as well. Nowadays got 2 and 3 types of combination therapy. One is to bring the receptor, the CFTR receptor out. Another one is to make sure the correct channel is open. So it's like a modulate each other. Okay, so there's also like lobectomy, pneumonectomy, lung transplant, and advanced care planning in the late stages lah. Okay, so depending on how you go rank lah. So for cardiology now, generally for cardiology, just a quick one. To me, cardio is I would feel cardio is easy, but at the same time, cardio can be killer because if your diagnosis is wrong, then you literally won't get the mark. Sometimes you get half of the mark, or sometimes you won't get any mark. Just maybe you just got the mark for welfare. So it's very important because cardio, the sign are very solid, and if you are not very sure of your finding, you need to find the main finding. You may not want to present everything because at the end of the day, you still need to come with just one diagnosis. And cardio generally can be differentiated into three possibilities: whether you're dealing with a native valve problem, mechanical so-called prosthetic valve problem, or you're dealing with congenital heart. So these three possibilities. Valve can be isolated or mixed. Usually commonest is being mitral stenosis, regurg, aortic stenosis, aortic regurg, can be pulmonary stenosis. Therefore, it's important to screen for syndromic features. Okay. If it's a mix, then it can come out in exam as well. Either it's a mixed mitral or mixed aortic lah. Usually we will not have mixed mitral and aortic, which is not fair. Cannot really differentiate. So we need to tell which one is predominant lesion. Let's say this is a mixed valve. And the second possibility is the prosthetic valve. Generally, they will not give a bioprosthetic valve because it's not very fair. Usually, they will give a mechanical prosthetic. So it's only single, like mitral or aortic, or dual, like dual valve replacement. Sometimes can have triple valve replacement, especially they repair the tricuspid valve. But most of the time, if they do the tricuspid valve repair, they are doing what we call as TVA, which is a tricuspid valve annuloplasty, which did not involve any mechanical device. But sometimes very severe one, they may put in a mechanical prosthetic valve. So you can hear all the clicks. It's like, oh my God, what is this? So actually, you can have a triple valve replacement nowadays. Not rare, especially in a tertiary center. But bear in mind that your idea is just to you still want to differentiate whether this is a single valve or this is a dual valve. And these two, you cannot really identify wrongly. If you commit yourself, cardio is a station that you must commit yourself to one diagnosis. Cannot yo-yo like 50-50, you let examiner hint you. Cannot, the examiner will not hint you. The examiner will want you to commit. If your diagnosis is wrong, then it's wrong. Then your marks will be deducted. It's very straightforward. And congenital heart, you're talking about ASD, VSD, PDA. And it can come out as a dextrocardia. It can also come out as a so-called TOF, corrected TOF, or even Eisenmenger syndrome. Usually we have peripheral cyanosis with clubbing. Okay, so usually these are the possibility. So these are some useful clues. To me, when I approach to any cardiovascular station, this is my approach, which I feel very practical and useful. So first is actually look at the patient. Tell yourself, this is a young patient, this is a middle-aged patient, or this is an elderly patient. Because elderly or middle-aged, you're thinking more to valvular heart. Young patient to middle-aged, you're thinking more to congenital heart. Okay. Second thing is want to screen for any syndrome. Do you think the patient like look at Marfanoid, look at Down syndrome, look like for example, look like Noonan syndrome or Turner syndrome. So you want to screen for syndromic phases. Third is check for scar. Tell yourself whether there's scar or there's no scar. Whether there's midline sternotomy or there's lateral thoracotomy or there's any saphenous harvesting scar. Okay. If there's midline sternotomy, there's two possibilities, right? Whether this is a congenital heart repair if it's in a young patient, or this is a valve replacement with CABG. Okay. If there's a lateral thoracotomy scar, if you're a young patient, you're thinking more to BT shunt repair. Okay. It can also be due to bulectomy in Marfan syndrome. And the fourth thing you need to take note is the pulse. Because pulse is very important, just take some time to feel for pulse. The moment when I use my stopwatch is actually to time the pulse only. Okay, so I really time the pulse about 10 seconds because remember, cardiovascular station always enough time on. I still remember I practiced so many times of cardio. I finished most of the time 4 minutes and 30 seconds. Generally, not even 5 minutes. Before 5 minutes, I already finished. Even if I go one by one, I do maneuver for all. Generally very fast. If you do a lot, then you will realize that cardiovascular, you definitely got enough time, including auscultating the lung at the back, check for the scar, pedal edema. You want to lower down the bed from 45 to flat to check for any hepatomegaly, also enough time one. But generally, I don't do that. So, but generally, bear in mind that don't be too rushed. Peripheral sign you cannot miss. If you miss the peripheral sign in cardiovascular, you may not get the diagnosis. That's why the pulse is something that I will spend some time. Okay, I will time the pulse 10 to 15 seconds. First is actually to calculate the pulse. While I'm calculating the pulse, the heart rate, I want to feel for the character and the regularity. If the character, the volume is good, then I'm not worried. It can be normal or it can suggest regurgitation, be it mitral or aortic regurg. If the pulse volume is really weak, pulse volume is really weak, you're thinking more to stenosis. Okay, if it's a AF, then you're thinking more to mitral pathology. Bear in mind that not always, but possibly more to mitral, can be like aortic pathology as well. And if it's regular, you can think more to normal examination or this is aortic pathology. Okay, but sometimes patient with aortic stenosis can also have AF for some other reason like thyrotoxicosis lah, other reason, ischemic lah. So there's a lot of causes, but this is not a fail proof kind of clues, but this is the clue that can tell you what are the things that you need to observe. And perhaps the fifth thing when I examine the patient over the precordium is to feel the apex beat, whether it's displaced or not displaced. So you tell yourself whether this is displaced or not displaced. If it's displaced, then you're thinking more to regurgitation. It can be mixed valve, but it's suggesting more on regurgitation. And if it's normal, then it's more to stenosis. And bear in mind that apex beat is also important. If you really cannot feel the apex beat, what you do next is to ask the patient to lie at the left lateral position. Okay, if you still cannot feel, then you must make sure your another hand is actually feeling for the right apex beat to make sure you don't miss a dextrocardia. Sometimes the station can come out like dextrocardia with VSD or with ASD or just dextrocardia. It's possible. So that's why always remember dextrocardia is a possibility. Okay. So this is how I generally approach. Like I mentioned, it can be native valve, prosthetic valve, or congenital heart. Okay, and the scar is also important. Functional status also I will tend to remember. And at the same time, the scar, other than the lateral and midline sternotomy, sometimes can have some minimally invasive scar. I will discuss this during the next the scar station, which is just a recap from my previous session. So sometimes the pacemaker or the cardiac implantable device scar can be so faint and very high up. Sometimes you may miss it. So sometimes when you really want to sometimes when you want to check for the exposure, when you want to expose the precordium, make sure that you drag the shirt a bit higher up at the left upper side to make sure you don't miss a ICD or make sure you don't miss a pacemaker. Okay, so this is if there is a pacemaker or any cardiac implantable device, they will definitely calibrate that as 1 mark. Okay, if you miss that, then definitely your physical sign will be reduced. And syndromic screen is generally how I screen. I will remember this mnemonic, how men turn down. P is something very rare. You can mention just how men turn down. Okay, very emo, right? How men turn down. So it can be H is Hoff oran. You want to check for any triphalangeal thumb, any missing thumb, any short radius. This will give you a clue that maybe you are dealing with congenital heart like ASD or VSD. Williams syndrome is something like usually you don't feel it, but you will feel like triangular faces, a bit like Alfin like that. Then you're suspecting for congenital aortic stenosis. Man is Muffin, followed by ankylosing spondylitis and Noonan. Okay, Muffin, usually you will miss it, quite obvious. You're thinking more to MVP or AR. AS, ankylosing spondylitis, usually you won't miss it. You will see a guy that the neck cannot lie down flat to the pillow. Okay, so you need to suspect like aortic regurg or mitral regurg. Noonan, usually a bit syndromic as well. Usually you will miss it like a Turner like that. Usually the posterior hairline is very short and there's usually very short neck as well. And the breast tend to be very flat. So usually Noonan may or may not have some limb edema. The one side of the leg may have some leg swelling. So usually you want to suspect pulmonary stenosis. Turner syndrome, you suspect more to coarctation, quite rare, but generally in exam still common to have a aortic valve pathology. And then Down is a Down syndrome. So Down syndrome very easy. You look at the patient, you know that this is a Downy, and then check for any features to confirm your finding. So you're thinking more to AVSD, ASD, or VSD, may have isomenger as well, if no scar. And pseudoxanthoma elasticum is quite rare, but generally can occur in overseas center. Usually you check the axilla, is a bit like very flabby, like chicken skin, so-called the chicken skin appearance, and hyper joint mobility. And usually you want to suspect for mitral valve collapse. Okay, so etiology, usually how I remember etiology is very simple. If it's young, congenital. If it's elderly, then it's degenerative or calcification, right? How about something in between? So something in between, you can also tambah this IE or rheumatic heart. These two are the one. And if you want to tambah another two, you can mention autoimmune and connective tissue disease. All the hyperelasticity syndrome. What is MOP? Everyone ask me, a lot of people ask me when they read my notes on this, because I didn't mention this until you read the subsequent chapter. So MOP is actually the mnemonic I used to remember for all hyperelasticity syndrome, which include Marfan syndrome, osteogenesis imperfecta, pseudoxanthoma elasticum, and Ehlers-Danlos syndrome. So all these are hypermobility joint syndrome, in which they will have a very high Batten score. And autoimmune are those like SLE lah, RA lah, all those kind of other autoimmune cause. So generally, if you want to offer etiology for cardio, very straightforward. Can be due to congenital, degenerative, i.e. rheumatic, connective tissue, or even autoimmune. And investigation is also very straightforward. Template. ECG for the bedside, and a check for the cardiomagnetic chest X-ray, echo as a functional test to diagnose, to identify the lesion, exclude IE, as well as check for the severity and the complication. And want to offer angiogram or right heart catheterization if indicated. So this is generally how we mentioned. So this is the table that I tend to use, I tend to do when I prepare for my exam. Bear in mind that if you listen, if you listen ejection systolic murmur at the upper left sternal edge, you have to suspect for HOCM as well. There's a possibility of HOCM. Okay, and this is generally you can read through. So this is also a table I wouldn't go through because it's generally how I remember. There's some cutoff that's already recently changed. Like for example, ESC mentioned about 50-50-50 for aortic regurg surgical indication. But generally, all this you can read by yourself. How to differentiate between both, I won't go through. And this is something that I need to mention. How to differentiate between a patient that is clubbed as well as sinus. So you want to make sure you want to make sure that this is isomenger or this is a repair tough. Okay. Okay, so let's say that is usually they are quite young or middle age. So usually how we differentiate is check for any scar. If let's say there is scar, usually there's a midline or lateral thoracic, then it is suggestive more of cyanotic. Sometimes may not be tough, sometimes maybe like for example TAPVD or TGA, those kind of thing. But usually they will have some BT shunt as well as the midline sternotomy scar. So this is a repair cyanotic congenital heart. Okay. If no scar, usually the isomenger has no scar. Like for example, a VSD repair, this thing like that, usually do not have scar. But if they have scar, then it means that this is a failed repair. No? And usually for murmur wise, TOF usually will have either ejection systolic murmur or early diastolic murmur. It can be due to after the functional pulmonary stenosis, which is the supravalvular pulmonary stenosis. It can be due to after they repair, it's too tight, causing so-called functional PS, or sometimes after repair, after some time, it actually gets into regurgitation. That's why you get the early diastolic murmur. Usually you only find cough with this, like an AST kind of ejection systolic murmur, but there's no splitting of S2. Isomenger usually will have no murmur, but bear in mind that isomenger means got pulmonary hypertension, cyanosis, everything. Pulmonary hypertension can lead to tricuspid regurg, and this tricuspid regurg may lead to your pansystolic murmur at the tricuspid area. So remember that if they got pulmonary, got PSM murmur to suggest tricuspid and accentuated with inspiration, and let's say there is a split second heart sound at the pulmonary area, then you're thinking more to isomenger with pulmonary hypertension secondary to ASD. Okay, so I must mention that. And pulmonary hypertension usually repair TOF have no loud P2. Okay, usually no loud P2. The moment you hear the loud P2, you must feel for parasternal heave, and whether if there's a pansystolic murmur again, you must tell that this is all signs of pulmonary hypertension. Very commonly, as a major, definitely we have pulmonary hypertension. Okay, so this is some clue to differentiate. So for cardio, want to end examination to observe the chart, fundoscopy, bedside distich, ECG. This is something that I also want to mention. These additional two things. If you are dealing with mechanical prosthetic valve, be it aortic or mitral, you must. To me, I will make an effort. If I know that this is mechanical valve, I will tell I will. Before I check for the pedal edema, I will straight away, after I listen to the lungs at the back, I will go back to the front, ask patient to do a pronator drift for me. Just a showmanship that whether there's any evidence of thromboembolism. which is evidenced by stroke, because we know that mechanical valve is predisposed to clot, and therefore patients need to be on warfarin, vitamin K antagonist. And for that reason, when I complete my examination, I will also mention that I want to check the patient INA book for the record and the trend to make sure this achieve therapeutic target. Okay, so the presentation, usually I will mention this is a young man or young lady with a working diagnosis of this. And in terms of severity, I'll mention about severity and whether it's symptomatic or not based on the scenario. Okay, if patient has SOB, then it's symptomatic lah. Additionally, got any syndromic features, scar or devices. Complication, I will want to mention whether there's any complication or heart failure. So I can combine both to mention whether there's any CREPS, risk JVP, things like that. And I want to mention there's any pulmonary hypertension. So pulmonary hypertension, PH and T. So that's how I remember. Palpable P2, personal HIF, and tricuspid regurg. Pulmonary hypertension, right? Right heart failure is a raised JVP, hepatomegaly, and foot edema. So RHF. Easy to remember this way. As I mentioned, syndrome basically usually have cyanosis or clubbing, and enclubbing. Usually we have a lot P2 as well. And generally have no murmur unless they develop into severe pulmonary hypertension causing TR. Okay. You also need to mention whether patient have AF or not. And for prostatic valve, you must mention that there is any evidence of thromboembolism, anemia, valve failure, or IE. So generally how I remember is TAVI. Thromboembolism and anemia is something that I need to mention. And for prostatic valve, I will mention that there is no evidence of regurgitation murmur. For example, for mitral valve replacement, you don't want to hear a pansystolic murmur to suggest mitral regurg. For example, in aortic valve replacement, you don't want to hear early diastolic murmur to suggest aortic regurgitation. So usually for valve, mechanical valve, you don't want to hear any murmur. Can be functional sometimes. Okay, so you need to differentiate. So IE stigmata also you should mention, and you offer the etiology. Investigation, like I mentioned, ECG. Blood, why you just want to make sure inflammatory marker and the 3 sets of culture to suggest IE. Functional echo, you must mention the indication why you want to do echo. Imaging, X-ray, non-invasive structural valvular may need to do CMR or CT, CA or things like that. Invasive want to do angio before surgery, valve replacement. Supportive can be due to this, how to reduce the cardiovascular risk, cardiac rehabilitation. Specific, you can mention all this, just goreng. I think everyone is okay. So neuro, I think I will skip the neuro because I feel like there is one particular session that we can talk about neuro lah. Generally, I won't go through all because I think the next session is going to be a bit of repetition if I go through. Okay, just go to summary. Just make sure that everyone practice with friends. Short case is something that we should score full marks. We should really score full marks. Okay, so we must really practice until you feel your approach is smooth, can finish by 5 to 6 minutes, and you should able to present confidently. Present to your friend who is also preparing the exam at the same time, correcting each other. Then you will really get the smooth, get the flow even faster. Okay, and bear in mind to mind mapping all these common cases that can come on in exam. You must already have the template on how to go into discussion, and how to localize the lesion, and how to tally with all the signs, summarize the finding. All this must be already in our mind before we go into exam. And we should aim for perfection. Okay, it's very possible to aim for perfection, but I remember my cardio, abdo, and also respi is all full marks, and only my neuro, because I didn't manage to finish on time, I only got minus about 2 marks for my neuro for the short case. But generally, if you do smooth enough, you should able to get full marks. It's not possible. The only problem is if you are not able to catch the hard sign, and you cannot tally and you confuse yourself with all the soft sign, you may not able to get the full mark because examiner may think that your diagnosis is not accurate. Okay, so the next thing is to expect the unexpected. Okay, and also important to be honest and admit own limitation during the Viva session. If the examiner query you whether there is things like that you didn't check, you just say, oh, I'm sorry, I didn't check for that. But if provide adequate time, I will definitely check. Okay, please be honest and admit our own limitation. And lastly, please rest well before the examination and pray for the best. Okay, so this is it. This is the a short session today. I'm going to end now. Is there any question?